Thank you everyone for coming out to our research fundamentals for May. Today we are welcoming David Avery, who is TRI's Director of Clinical Research Operations. He is a very busy man, so we are very thankful that he is able to take an hour out to come talk to everybody about clinical trials and TRI's role in clinical trials. I think it'll be a really interesting presentation, and I'm sure I will learn a thing or two. Our research fundamentals is taking a break for the summer, but we should be back in either August or September, so please pay attention to our TRI announcements and our website for more information. And without any further ado, we're going to have Maisha stop sharing her screen. We're going to turn it over to David so he can share his screen, and we'll start the presentation.
Hello, everyone. So I am David Avery, and I am the director of our central clinical trial unit in TRI that supports most of the non-oncology clinical trials done at UAMS. You might see reference to Clinical Trials Innovation Unit, or the acronym CTIU. That's just the catchy name that looked good in a grant for our clinical trial unit. We're made up of 3 teams that handle research finance, regulatory, and then a pool of study coordinators. And I'm going to talk more about those resources and what services we offer as we go through this presentation. Just quick objective. So I wanted to focus on the resources and services that are available at UAMS to support clinical trials, but rather than just shotgunning a bunch of resources, I was hoping to organize this kind of around operational phases and workflows that are common to most clinical trials. Clinical trials encompass such a broad range of research, it's a little bit difficult to do. And a couple of other clarifications I've thought of here. I'm focusing mostly on the processes that our group in TRI support, which is the non-oncology clinical trials at UAMS. So there is a sort of a mirrored office in the Cancer Institute that supports all of the cancer-related clinical trials at UAMS. And we share a lot of systems and processes and work really closely together. So I think most of the information I'm going to present is still relevant even for cancer-related clinical trials. And then I also thought that some of you may practice primarily at Arkansas Children's Hospital or in Northwest Arkansas. And so again, a lot of the resources I'm going to talk about are available to researchers at any of these centers. But some of the contacts and systems might be a little less relevant. I think generally though, what I've tried to focus on are kind of the fundamental processes and workflows that are common to all clinical trials. So just to help set the scope, this is the NIH definition of a clinical trial. And the real keys here that distinguish a clinical trial from other types of human subject research are that the participants are prospectively enrolled in the trial. There's an intervention that's defined by the study design, by the protocol. So not observational in nature, intervention not defined by a clinical provider on a case-by-case basis. And then the outcome measures, like the purpose of that trial is really designed to measure some health-related outcome that evaluates the effect of that intervention. Okay, so this little graphic's just another way of helping to clarify, how clinical trials are distinct from other types of human subject research. So prospectively enrolling subjects, an intervention that's defined by the protocol, some type of assessments or measurements that are focused on determining the effect of that intervention. And one of the things that's challenging about this, to talk so generically about clinical trials, is this intervention could be any number of things. So we a lot of times think about clinical trials as investigational drugs and medical devices, but the intervention could be a behavioral intervention. It could be It could be an app that's loaded onto a participant's phone. There's just a really broad range of different types of research that meet this definition of a clinical trial. All of those have, some unique challenges and require unique resources. I'm not sure it's possible to, have any one individual talk with any authority on all of that. But so I'm going to focus on what I consider kind of the fundamental processes and workflows and resources that support a lot of clinical trials. I'd say normal process, but it's difficult to define normal. I like to say that, normal in talking about clinical trials is, it's a median of a really broad range. It's not that 90% of clinical trials look exactly like this. And then my intent was to organize these resources kind of by the 4 operational phases of the trial. So this is concepts that apply across all types of clinical trials. So from planning, startup, implementation, and closeout. And this slide is just some examples of the activities that occur in each of these phases. And then I wanted to talk about the resources that are available at UAMS to support each of these activities. So from planning, we're talking about confidentiality disclosures, feasibility assessment, site selection visits, gathering all the documents that we need to begin regulatory submissions. And then in startup is really that period of time where we're making our regulatory submissions, we're negotiating budgets with clinical trial sponsors, setting up our data collection systems and making sure that all the staff are trained. And then implementation is going to be the actual conduct when we're enrolling subjects, completing visits, monitoring visits from sponsors, financial management of the trial, and then closeout wraps that up. So I know a lot of times we think clinical trial conduct is, it's that implementation phase. This is what goes on, but there's a lot of moving parts around that make that happen. One of the important things to consider are different study types and funding sources that kind of impact what those workflows look like, and what activities are necessary in each of those phases. So I've organized this into kind of 4 groups that pretty well cover most of the trials. We have single site investigator initiated trials, which are locally developed studies. Multi-site investigator initiated trials. So that might be a locally developed studies where we have other academic centers that are participating as sites in the trial, or it could be a study designed at another academic center somewhere and we're participating as a site in their trial. And then these last 2 groups are going to look more similar operationally. So multi-site trials, either sponsored by pharma or nonprofit organizations or cooperative groups where there's a central sponsor somewhere that's designed the trial and is administering the trial, and we're a site participating, enrolling participants in their trial. So right here is where my plan started to fall apart. So thinking about the planning phase, right off the bat, there's a lot of difference in, what happens during that planning phase for a locally developed study versus an externally sponsored study. So for a locally developed study, the emphasis really is on designing the study, developing our protocol, getting all of our logistics planned and making sure that the resources are in place. All of the materials that we need to move into regulatory approvals and startup have to be developed here by the UAMS team. Where with externally sponsored trials, all those materials are provided to us. So the emphasis is more on having appropriate contracts in place, us assessing, feasibility for our own site, whether we have the resources needed to successfully participate in that study, making our case to that sponsor that we are going to be a good site, that we're well qualified to participate in their study, then gathering all those materials that we need to begin our regulatory submissions. And what occurred to me here, both, I've got feasibility bolded there, is that really in both cases, like a big part of this planning is assessing feasibility. And what feasibility is making sure that we have all the resources necessary to be successful with the trial. So my plan to sort of talk through operational phases and address resources, in each of those phases doesn't necessarily make sense, because we really have to consider all of those resources at the very front end in the planning stage. This is a screenshot from our TRI services portal that highlights services offered by TRI or that TRI can connect researchers with. I've highlighted a number of them that I think are relevant for clinical trials. Then we'll talk through some of those in more detail. This is accessed from the TRI website. The actual portal has not a very user-friendly web address, but if you go to the TRI webpage, there's a link right at the bottom to request services. We'll get you to here. So things like biostatistical support. TRI has an equipment library, which offers things like tablets, iPads that maybe you need to use in a clinical trial to have participants complete surveys. Plain language assessments and Spanish translation for informed consent forms. A lot of bioinformatics support. The rural research request consultation is a relatively new service that I'm going to talk a little bit more about. It's looking at the possibility, it's one of our goals, is to expand more clinical research into regional programs around the state instead of having it all so consolidated in our larger campuses. And then at the bottom there's an I'm not sure option where you can choose that option, and it's going to connect you with someone at TRI for a consultation to talk through your plans and questions and make sure that you get directed to the resources you need. So thinking about that planning stage with a locally developed protocol, a locally developed study, the first thing we're doing is trying to design the study and define our protocol for it. So this is one of the services that TRI does offer, is a protocol development assistance. Some of you have probably worked with Michael Bailey. We've got a number of people in our office that can help with this. Michael is most likely the person that would be your contact. He's has a lot of experience in clinical trials and clinical research, technical writing, but I think Michael's best qualities is he's just the most affable person you'll ever meet. He never meets a stranger, and he can help connect you with all of the resources available on campus that you might not even realize that you need at this early stage of protocol development. One of those resources that Michael would refer you to very early on is another one of the formal components of TRI, our biostatistics, epidemiology, and research design component. So kind of one of the fundamental principles in clinical trial design is we sometimes think about statistics as something that's done at the end of a study after we've gathered a lot of data. But it's really important to have that statistical team involved on the front end in designing the study, to make sure that the study design is sound and is going to generate meaningful data that's capable of answering your research question. Another of our formal components is our Comprehensive Informatics Resource Center, led by Dr. Fred Pryor from Biomedical Informatics. And they offer access to a lot of different informatics resources that can be relevant to clinical trials. There's a list here of the ARCDR you might have heard of as the UAMS data warehouse. ARCHRIS is essentially our locally developed CTMS program. Redcap, Clara, I'm sure that you're aware of. We're going to talk about some of those that are most relevant in a little more detail. But this is a resource available from the TRI portal. You can request a consultation, and they can direct you to the resources most appropriate based on the type of work you're trying to do. Redcap is one of those resources available through our bioinformatics component. Redcap is an electronic data capture system. It was developed at Vanderbilt. It's open source. It's been adopted and is being used all over the country. It's really a user-friendly system. It has capabilities to do electronic informed consent, administer surveys, create more traditional data capture forms. It has some capability to be integrated into Epic and automatically populate certain fields within your database. So the thought here is if you're developing your own study here locally, like in that planning stage, you've got to be thinking about how you're going to manage the data that you're collecting. Redcap is probably the most user-friendly option that we have available. It gets a little bit confusing as there's multiple instances of Redcap being used across UAMS and Arkansas Children's. Some of those have some slightly different capabilities as far as integration with Epic or progress that's being made towards Part 11 compliance, which is relevant for FDA regulated studies. But by requesting access to Redcap through the TRI portal or a consultation with our informatics group, they'll get you directed to the instance that's would best fit your project. The ARCDR is the data warehouse, also under the oversight of our informatics component. I think a lot of people think about the data warehouse as a tool for doing retrospective research, but it's really invaluable in the planning stage for a clinical trial for the purpose of cohort estimates. I think a lot of time faculty overestimate the population that's available to be enrolled into a study. A physician anecdotally thinks that he sees X numbers of patients that would qualify per month. With the data warehouse, we can real quickly put together some, fairly complex, sophisticated queries to look at the actual eligibility criteria from a study protocol and get real numbers to tell us, do we have the study population to be successful with this trial? A real good example, just a few weeks ago, we were helping one of our faculty members from emergency medicine was interested in an outpatient trial for COVID, mild to moderate COVID-19 patients. So we've done a lot of clinical trials in COVID-19 over the last year, has mostly been in more severe disease with patients that are inpatient in our hospital. Anecdotally, that faculty member thought, oh, I probably see this number of patients that present to the ER, so that we could enroll 10 or 15 patients per month in this trial. When we put together that query to look at actual numbers that we're presenting per week, considering the specific eligibility criteria with comorbidities and other factors, it came down to we could realistically hope to enroll about 1 per month. So you can go a long ways and invest a lot of effort in a trial that doesn't have a chance to be successful if you don't do a good job on the front end evaluating if you have the population needed to enroll in that study. The Office of Research Regulatory Affairs is a resource outside of TRI, but it's really critical if you're planning a study, designing a locally developed study that's going to involve any FDA regulated products. So any type of drug or medical device study that might require an IND or an IDE. And it's not always real obvious. Sometimes we think, well, this is an approved drug, it doesn't require an IND. But when you use it in the context of a clinical trial, all of that changes. So in the practice of medicine, a physician can order a drug off label. It's not an issue. Within the context of a trial, if you're studying an off-label indication, using that drug in a population that's different than what the approved labeling is, it might require an IND to conduct that work. Susanna Carlisle is the director of ORA. One of the other things that's a little bit unique about investigator-initiated trials at UAMS is the concept of sponsor within that trial. So sometimes we think about sponsor as the funding agency for a trial, but sponsor actually has a regulatory definition defined within the FDA regulations. And there are certain responsibilities and obligations for a sponsor relating to trial oversight. A lot of academic centers use a model where the investigator acts as a sponsor investigator, so they're fulfilling the role of both sponsor and investigator. Here at UAMS, we do it a little bit differently, and the institution acts as the sponsor. That has some, it's helpful in that it takes some of that heavy lifting and regulatory burden off of the investigator. It provides a resource for monitoring. So one of the really significant roles for a sponsor is to monitor the conduct of the trial. ORA has a staff of monitors that do that and fulfill that obligation for all of our investigator-initiated drug and medical device trials. I'd note about device trials that, kind of like drug trials, it isn't always obvious whether a study is going to need an IDE. We see a lot of studies with things like an app for a phone or software related for image post-processing that we don't immediately think of as a medical device, but those are regulated by the FDA as a medical device, potentially require an IDE. Also housed within ORA is the resource for clinicaltrials.gov registration. And this isn't specifically an FDA related rule. So there's a number of different reasons that clinical trials have to be registered on clinicaltrials.gov. Listed here, an applicable clinical trial is the term per FDA's regulations that includes most drug and device trials. But then the NIH also requires any clinical trial that's funded by NIH to be registered. The International Committee for Medical Journal Editors has recommendations that should be viewed as a requirement that a trial has to be registered in order to publish in those journals. And then there are also CMS requirements where certain types of studies have to be registered for billing purposes. Claims going to Medicare have to have that clinicaltrials.gov identifier on the claim, or CMS will reject it. Recruitment is another thing we need to think about early on the front end, whether we're talking about a locally developed study or a sponsored trial. We need to have that recruitment plan in place to know whether we can be successful, but also to have those materials. Those recruitment materials are going to have to be reviewed by the IRB and need to be included in your regulatory submissions. The AR Research Registry is a registry of mostly Arkansans. So this is managed by TRI. Dr. Gene McSweeney organizes the research registry. We have about 7,500 volunteers that have signed up now. So this is available as a resource through TRI. You can search the registry. People that sign up indicate certain therapeutic areas that they would be interested in participating in research. There is, rightfully so, a real emphasis on including underrepresented minorities in clinical trials, and the AR Research Registry has a really nice, diverse, representative sample of the population of Arkansas. So Dr. McSweeney's they've done a really good job at going into different communities and cultures to sign up participants. So it's a good resource. Flyers and brochures, TRI can help develop. Or if you're talking about a sponsored trial where those materials are provided, TRI can help distribute through social media campaigns. Epic MyChart recruitment is a newer technique that we've piloted with just a couple of studies. So we can work with the Epic team to identify patients within UAMS's medical record that potentially meet your eligibility criteria, and then send an approved recruitment message to that patient through Epic MyChart. Then the patient has an opportunity to respond, whether they are interested in receiving more information, and that response goes directly back to the study team to then follow up with direct contact. And then another really good resource is, again, the ARCDR. So we talked about it for doing cohort assessments, but we use it a lot in recruitment also. So they can create, say, a weekly report or a monthly report of patients that meet your eligibility criteria. And then if you have the regulatory approval in place, you've got that list to then contact to recruit for your trial. In that planning stage, we've got to think about where the study activities will occur. Some different common options here is that are largely defined by the scope of the research. If those study activities and study visits are going to be integrated with clinical services, they may be conducted in the hospital or in our outpatient clinics. And that's largely defined by the research and requirements of that research. Anything involving infusions or imaging, those are the only resources that are available are those clinical services. And UAMS has good processes in place to make all of those clinical services available for clinical trials also. TRI, we have an outpatient research clinic on the 3rd floor of the Institute on Aging, where we have five exam rooms that were just renovated within the last year. They are really nice. We have 2 labs for processing samples. One of the things that's become a little bit challenging in the last year, there's so many changes and new requirements that have been related to COVID. is biosafety approval now is required for all clinical trials that involve any type of human samples. So if you're collecting a blood sample from, even a healthy control patient that has to be processed to plasma and sent to a central lab, you need to have, that has to be done under BSL-2 conditions, and we have to have a biosafety approval in place. We have an umbrella biosafety protocol in place for our lab in IOA that we can add clinical trials to. So for most types of common sample processing, we can just add that protocol to our existing IBC protocol, and it's considered approved. We have a biosafety cabinet and centrifuges and the equipment necessary for most of that. We have 2 -80 freezers that can be used to store specimens for batch shipment at a later date to central labs. And then one of the newer options that's starting to emerge for clinical trials that we're really excited about is the Rural Research Network, which is a collaborative program between TRI and the Cancer Institute to establish research infrastructure in 8 regional program clinics around the state. Some of those sites now have dedicated study coordinators embedded in that regional program clinic. They have a number of studies already being conducted in those clinics, but for UAMS researchers, each of those sites, has some unique resources and offers access to special populations that we're really excited about continuing to build that program and expand that option. I mentioned it earlier. On our portal dashboard, you can request a consultation if you'd like to discuss whether a study might be a good fit to conduct within that rural research network. So a lot of that, some of that applies both to locally developed protocols and externally sponsored studies, but with externally sponsored trials, with cooperative group trials, pharma-sponsored trials, the process is going to look a lot more similar from study to study. And TRI has an easy button to offer you here, and Miss Pam Christie, who leads our stakeholder engagement programs. So she serves as a central contact anytime you have a new clinical trial opportunity that you're interested in moving forward and exploring. She will facilitate getting CDAs in place, help with answering feasibility questionnaires, scheduling site selection visits, so that PSSV here is for a pre-study site visit. So kind of one of the standard things that happens with every clinical trial. It's an obligation of the sponsor to make sure that they're placing that clinical trial in a site that's well qualified to conduct the research. Historically, that's done through an in-person site qualification visit. Over the last year, we've seen a lot of movement to doing those through virtual site qualification visits. But Pam can coordinate all of that effort. And we literally use this list right here as a checklist of all the materials that need to be done during that planning stage before we move a project into startup to actually start submissions. So looking forward as we move into startup, we're going to talk a little bit about Clara, and I'm guessing that a lot of you are familiar with Clara. So Clara, a lot of times people think of it as this is the IRB system. This is how you submit a study to the IRB. But there's a lot of other things that are happening within Clara. Like Clara is the tool that connects a lot of the resources related to clinical trials. So it contains our budget development tool that interfaces with Epic to set research fee schedules. It interfaces with our ARCHRIS CTMS programs. There's a contract module to Clara where our legal team manages all of their contract workflow for negotiating, executing clinical trial agreements. And then it obviously contains the IRB workflows. And one of the things that's been changing a lot over recent years is that it isn't always a full review that our local IRB is doing. So more and more clinical trials are being overseen by an external IRB. So for NIH-funded studies, they now require oversight by a single IRB. Most pharma-sponsored trials are using a commercial IRB like Advara or Copernicus. So in those cases, the local UAMS IRB performs what they call a context review before the submission is made to that external central IRB. And this is a horrible busy slide here that kind of illustrates Clara Workflow. And I don't want to talk a whole lot about this, but as busy as it is, I think it does a good job of illustrating how much more is happening in Clara than just an IRB submission. So it includes financial review, where we develop budgets, negotiate budgets, which is linked with our contracts process, or that we talked about earlier has a function within Clara. The research pharmacy, investigational drug service has a role within Clara. The biosafety committee, conflict of interest. There's a lot happening within Clara. I'm going to talk about a few of those things in more detail. And so even with studies that are under the primary oversight of an external IRB, we still have to have those other essential processes that are done within Clara completed in order to set up all of our operations and systems once the study opens to begin enrolling participants. And so all of that process has a lot of moving parts. There's a lot of players. It is a little bit complex and complicated. And luckily, you don't have to worry about knowing every detail of that. So one of the services within our TRI clinical trial unit is a regulatory service to manage your startup, manage your IRB submission. So we have 5 regulatory specialists on our staff currently that will serve as kind of the primary point of contact as you move through the startup process. They will create and manage that Clara submission for you, both for your initial review and continuing reviews. They can make that submission to external IRBs for studies that are overseen by another IRB, and then maintaining all of the essential regulatory documents and training records that are required throughout a study. So things like by essential regulatory documents, there's 1572s for drug and device trials. There are lab normal ranges reports for any study involving laboratory tests, training records like CVs, good clinical practice training, things that are required to show, again, that we're qualified to be conducting this work. This is another very busy screenshot of the budget module that is embedded within Clara. And it's a little bit complicated, and I just wanted to make the point that this is a fairly sophisticated tool that it interfaces both with Epic. So you'll see that all of the procedures in the study here are scheduled by CPT codes. And that allows that interface with Epic. So every activity within the study has a price, has a cost. So when our team is developing that budget, they're looking at everything involved with the study, building it out in this matrix. This sort of mirrors the schedule of time and events in the protocol, and it's a schedule for each participant in the study, where you see R's and I's that indicates when each of those activities is scheduled to occur. But it also confers the coverage analysis for each of those activities. So another kind of fundamental part of any clinical trial that involves clinical services has to have a comprehensive Medicare coverage analysis done to decide who the appropriate payer is for those services. So clinical trials that are integrated with clinical services often involve a lot of procedures that are standard of care and could be paid by that patient's insurance in the usual manner. But we evaluate every protocol to decide for every activity within that, who is the appropriate payer. Medicare is the standard that everything gets measured against. So if Blue Cross Blue Shield would be willing to pay for a procedure within a trial, but Medicare would not, then that's determined that that's a charge that needs to be paid for by the study. So this is the tool we use to develop the budget when we're negotiating a contract with the sponsor. This information goes to Epic to set the fee schedule for when these activities actually occur. It informs Epic where that charge needs to be routed when it's created so that it's either billed back to the study or allowed to route to the patient or their insurance with appropriate modifiers to indicate that it's related to a clinical trial. And then it also interfaces with a patient study calendar that we're going to talk about that is a sort of a patient by patient schedule of activities where activities can be marked complete. And it sets up our accounting system and lets us know when contracted activities have been completed and need to be invoiced to sponsors so that we are expecting payment according to our contract terms. This is another of the three core units within our clinical research unit. We have this finance team that's made up of 6 people currently. 4 of those primarily work on the front end, pre-award, developing those budgets, negotiating budgets with trial sponsors, making sure that those budgets are developed within Clara in the format that's going to be compatible to communicate with our other systems like Epic and ARCHRIS. And we have 2 individuals that focus primarily on post-award accounting. So they review charges routing through Epic to make sure they go to the correct payer. They can help distribute participant stipends or travel reimbursements if that's part of the study. And then they invoice our study sponsors to make sure that UAMS is getting paid for the work we perform on these trials. I wanted to highlight ClinCard here. So ClinCard is a commercial service through Greenfire that TRI pays the licensing agreement on. And what it is, it's a reloadable debit card that's designed to be used for paying research participant stipends and reimbursements. It's a really handy tool that we make available to all of UAMS. Again, TRI pays the licensing agreement to use ClinCard. Each study pays just the cost of the cards that are distributed, which is about $3 a piece. So if you've got a study that's going to involve multiple visits where there's a stipend or a travel reimbursement associated with each visit, you can provide this card one time. After each visit's completed, we can help load funds onto that card. It's a world more simple than petty cash accounts and Walmart gift cards, if you have any experience with UAMS's processes on those. Research contracts. So most clinical trials are going to involve agreements with, or any clinical trial that has any relationship with someone outside of UAMS is going to require an agreement of some type. So we have 2 full-time research contract attorneys that are housed in the Office of General Counsel. They may have already hired a 3rd. I know they've been working to get to 3 contract attorneys. We keep them busy with the volume of trials and new agreements coming through. They actually handle any research-related agreement, not just clinical trial agreements. So data use agreements, material transfer agreements, the confidentiality agreements that we always do on the front end of a new study. They are your contact to process those agreements. The IRB I wanted to mention, sometimes we think about the IRB as a compliance function, but our UAMS IRB really should be viewed as a resource. They're super responsive, super helpful. We get questions about how long it takes for something to be reviewed, how often does your IRB meet. So we technically have 4 IRB committees locally. They meet the first 4 Tuesdays of every month. So normally that's a weekly meeting, unless a month includes 5 Tuesdays. They are AHRP accredited and undergoing a review of their accreditation later this month. So when I say they're responsive, I should clarify that that's most responsive when they're not in the middle of an AHRP accreditation evaluation. And they also have a really good website that's got some good tools and templates on it. And I appreciate that they have like the full library of all of their policies available on their website. So I find myself frequently going to their website and accessing their policies to answer a question. ARCHRIS is a suite of locally developed and open source informatics programs to support clinical trials. The little top banner here is a screenshot of all the different programs that are available. So a lot of these are relevant only for, in certain situations, specific study types, but there's a handful of these that are really a fundamental part of the way we do clinical trials at UAMS. So the RPRS is the Research Participant Registration System. So this is the central registration system that every clinical trial participant is registered to. This registration is how we let the medical record know how it communicates with Epic, so that that patient's chart in Epic is flagged as a participant in this trial. It communicates with the other ARCHRIS systems like Patient Study Calendar, which takes and essentially creates a calendar of the expected study procedures for each participant that's registered. So when you register a participant in RPRS, it's broadcast to Epic, it's broadcast to Patient Study Calendar. Then within Patient Study Calendar, you have the expected schedule of visits and activities where they can be marked complete as they're completed. Marking those completed communicates then with our clinical research accounting system mentioned here as part of ARCHRIS. That's how we invoice sponsors, make sure that we're getting paid according to our contract terms. Open Clinica is another EDC system, not quite as user-friendly as Redcap is, but historically it's been the best option we have available when a trial requires a Part 11 compliant EDC system. So anything that's FDA regulated, all of the electronic tools have to be validated as Part 11 compliant. Open Clinica is. And then Event Tracker is another system that's used for tracking kind of study level milestones, study level events, whereas Patient Study Calendar is tracking completion of patient level activities. The third team within our TRI clinical trial unit is our pool of clinical research nurses and study coordinators. So I'm not intentionally making clinical trial administration sound complex, but the reality is that it is, and it's very difficult for someone that is only occasionally engaged in clinical trial administration to maintain a current working knowledge of all of these systems and processes and workflows that are involved. So TRI offers this staff of clinical research professionals as a central pool to help with studies across the campus. We currently have 17 full-time staff within this unit. That includes 2 APRNs, 9 RNs, 5 unlicensed study coordinators, and a medical assistant that works primarily for lab processing and phlebotomy. We have 3 additional PRN nurses currently that help with after hours and weekend activities. We do not offer 24/7 coverage, which comes up from time to time as a need for a trial. What we can do with our PRN staff is if a trial has an isolated activity, a pharmacokinetic lab that needs to be drawn on a Saturday, we can accommodate those kinds of one-off requests. An odd spot in my presentation for this, but so our research pharmacy should not be an afterthought. But we do have an investigational drug service that's managed by the UAMS pharmacy department. They have outpatient pharmacy that's located in our cancer institute. They work with our inpatient pharmacies for trials that involve investigational drugs administered on the inpatient side. They have a really cool new software called InCoop that manages all of the investigational drug accountability. One of the best features of this over the last year is that it allows study sponsors to monitor pharmacy activities remotely, the same way that we can provide remote access to Epic for monitoring clinical trial data. And my last slide here, which isn't a great fit, but I wanted to mention this. So this is a unique case that someone would want to look into this resource, but for someone wanting to develop a more complex clinical trial, a multi-site clinical trial that we don't necessarily have all of the right resources to support here on campus, through our CTSA membership, we have access to the CTSA Trial Innovation Network. And so it connects us with resources at Duke, Vanderbilt, Utah, Johns Hopkins, a lot of expertise in administering large multi-site clinical trials. If you have an idea that you'd like to explore, through TRI, we can request a consultation with the 10. We'll talk through the proposal, what next steps might be. There's the opportunity to use resources from the 10 to actually conduct some of the work. So they have coordinating centers that are well-staffed and experienced at coordinating multi-site trials. Or it might be that they return a list of recommendations and we realize that we're capable of supporting all of the needs here locally. And I've taken more time than I intended to. I wanted to go back again just quickly to a screenshot of our TRI website. There is the request services link that can get you started to connect with any of these resources. I have not left a ton of time, but I would be happy to answer any questions if anyone has questions.
Hi, you mentioned early on that nonprofits sometimes were sponsors, and I was curious about hearing more about that because I didn't know that that was a thing.
So a lot is that, the Parkinson's Foundation organizes and conducts clinical trials, or, usually disease-specific nonprofit associations. They work practically a lot like, say, the NCI cooperative groups do, in that you have a nonprofit entity that's administering the trial, coordinating the large multi-site trials.
So it's usually like for a certain disease, something like that?
Yes.
Yeah. Thank you.
I know there was a question about fees and which services are attached to fees and which are free.
Yeah, so that's not always black and white. I'm seeing now there was some discussion in the chat. I'm sorry, the way my silly monitors worked is I couldn't see the chat at all while I was talking. So our clinical trial unit, the 3 core teams within our clinical trial unit do operate on a fee-for-service basis to support sponsored research. But most of the time, we're able to work the fees out within the funding that's available for the project. For unfunded research, we're less able to own that work for you, but we can still help you in an advisory capacity to kind of help you navigate the systems and connect you with the resources. Most of the other systems, the ARCHRIS systems, things done within those, the ARCDR, there are not fees associated with those services. If someone has a question about a specific resource, it'd probably be easiest to address that one-on-one separately to make sure I'm giving you good information. I see a question that I'll address real quickly in the chat about why are separate and how do the services interface. And the reason cancer is separate, it's part of the initiative to get NCI designation for our Cancer Institute is the Cancer Institute needs to have oversight and demonstrate that they're managing the cancer-related research done at UAMS. It's separate only in the sense that we have these two separate offices, but really our offices operate almost identically. So when I'm talking about coordinator services and regulatory services and the financial operations, the Cancer Clinical Trials and Regulatory Affairs Office in the Cancer Institute does those exact same things for anything that's cancer related. I probably should have included in the slide somewhere, Sandy Annis is sort of my counterpart in the Cancer Institute, and she can help navigate you to the right resources for any cancer related trials.
Thank you everyone for coming. There will be a recording available for this. It'll probably take a little over a week. I am out next week, but we will get it up the week of the 17th. And keep an eye on our announcements for the seminars to pick back up in August or September. But thank you everyone, and thank you David, we really appreciate it.